Today we begin with an important topic called systemic lupus erythematosus. What is systemic lupus erythematosus? It is a chronic, autoimmune, inflammatory, connective tissue disease that can affect the joints and many other organs, including the skin, heart, lungs, kidneys, and nervous system. How does it occur? The pathogenesis of this disease begins with inefficient clearance of apoptotic WBCs. The persistent presence of intracellular components of these cells provokes the formation of antibodies. Thus, antibodies are formed against intracellular components of cells in the self. This pictorial representation tells us the pathogenesis. As you can see, when environmental triggers or genetic factors cause immune dysregulation, there is decreased clearance of apoptotic cells. This leads to the formation of self-antigens that trigger our immune system and cause the formation of antibodies. These self-antibodies then form immune complexes which deposit in various organs like the skin, the vessels, as well as the kidney. What are the systemic manifestations of systemic lupus erythematosus? The first and foremost is skin, where it causes malar rash, discoid rash, and photosensitivity. Oral or nasal ulcers. Third being non-scarring alopecia. Fourth is joints, that is upper limb predominant, non-deforming, non-erosive, small joint arthritis. This is the typical malar rash which involves the bridge of the nose, the malar prominences. The malar prominences, as you can see here, are involved. And it spares the nasolabial fold. We continue with discussing the systemic manifestation, the next being serositis, commonly involving the pleura pericardium but less commonly the peritoneum. The renal involvement includes 6 grades or 6 classes of glomerular involvement, which begins with the least minimal mesangial change and it ends at global sclerosis. Among the neurological manifestations, the most common is mild cognitive impairment, followed by psychosis, seizures, and sometimes a characteristic feature is auditory hallucinations. Among the hematological manifestation, autoimmune hemolytic anemia, which gives us a direct Coombs test positive, leukopenia can be seen, and thrombocytopenia can be seen. These are the classes of renal lupus. It begins with minimal mesangial lupus nephritis and it goes all the way down to class 6 of advanced sclerosing lupus nephritis. We can now see the difference between class 1 and 2 and class 5. As you can notice, there are not many changes in class 1 and 2. What is remarkable in this picture is there is only some mesangial expansion in class 1 and 2. But in class 5, along with mesangial expansion, there is deposition of immune complexes in the mesangium, and you can also notice that the globular basement membrane has thickened and there are subendothelial deposits as well. So a light microscopy of class 1 and 2 will only show the mesangial expansion. It might not show any proliferation and immune complex deposition. On electron microscopy of a class 5, what can be noted here is a subendothelial deposit. This is a capillary of the glomerulus and this is the endothelial cell and these are the cells inside the capillaries. So you can notice that the basement membrane is quite thick and there are deposits in the subendothelial space. How is the immunological profile in patients with systemic lupus erythematosus? They are ANA positive. This is done by a method called immunofluorescence. It is confirmed by ENA profile or extractable nucleic acid profile, and anti-dsDNA and anti-Smith are quite specific antibodies in SLE, anti-Smith being the most specific. Antiphospholipid antibodies, also famously known as the APLA, can be positive in these patients. This carries with it a risk of thrombosis. Complement factor consumption. Because of widespread immune complex deposition and inflammation, the complements are consumed. Thus, there will be decreased C3 and C4 levels. Last but not the least is direct Coombs test positivity, which gives us autoimmune hemolytic anemia.